Yo, welcome back, boys and girls, and anyone else who's joining us today. This is Mnemonics. I'm coming back with a brand new video. I'm actually pretty tickled about this topic that we're going to discuss today. So, that being said, if you like the video, click the like button. I don't have a ton of subscribers, so if you can do that, click the subscribe button. It'll entice me to make more videos when I literally have negative time to do this shit. So, yeah, that being said, let's get started. All right, you guys can read. All right, so like I say in all my videos, this is just a medical disclaimer saying that if you have a serious problem, go see a medical professional. Don't trust my dumb ass. Still watch the video. I'm not that dumb, but smart enough, but dumb enough to not help you in that sense. And this is for fun. It's just for education for me to kind of, have fun, kill some time in between shifts. So the whole point is go see a medical professional. Please don't see my ass. As you can already tell, I swear a ton. Shit, what the fuck was that? Okay, we're good. Yeah, I swear a lot. I'm not sorry. So yeah, just forewarned going into this video. Okay, so today's topic is going to be pain control. So I kind of thought about this when I was in the hospital a while ago, and someone came up to me like, "Look, this person is in like a shit ton of pain. Like, what do you want to give them?" And I actually had no idea. I didn't realize should I give them something small, like an NSAID, something really strong, like morphine. And I didn't know like when you should get something versus when you should not give something. And I looked into like YouTube land if there are videos on this. There are some like pharmacology videos on this, but none of them were really well done. So this is the whole point of this video, is to kind of give you more of that niche of what to do when someone asks you like, hey, what do you want to do? So that's the whole point of this video. All right, let's get rolling. All right, so this is gonna be the drug list. So we're gonna go through Tylenol, NSAIDs, codeine, tramadol, morphine, fentanyl, Dilaudid, also known as hydromorphine, and ketamine. And as you can already tell, it's going from essentially strength. I'm gonna use my cursor here. So it's gonna be from like essentially least potency to like more potency, meaning more in strength. You could argue one of these is probably stronger than the other, but you kind of get the point that ketamine's obviously can be more of a big gun compared to Tylenol. And in the red box here, these are actually going to have like the actual best mnemonics. The first four, like Tylenol, NSAIDs, codeine, and tramadol, like I'm essentially giving you information about these and a little bit when or when not to use them. But the mnemonics designed for this video are really meant for these last four that are in the box, because I feel like these are kind of the big hitters and things you really need to know about them when you actually pull the trigger to use these. So that being said, let's get started. Okay, so off the bat, this is Tylenol, which is acetaminophen. It's going to be used for analgesia, meaning think of anal, it's painful. I don't know from experience, but I imagine that it's not very pleasant. So analgesia means pain, and then fever. That being said, it's not an anti-inflammatory. So if your knee swells up, this shit's not going to do anything. So that's not what it's used for. It's used for pain and fever. So typically it's going to be like 325 to 650 mgs, and then PO means by mouth, and then Q means how much, and then it means every 4 hours. So you don't want to exceed 3 grams. So if you do the math, like 6 times 4 is like roughly 2,400. You don't really want to go over 3 grams per day. So side effects, it's metabolized in the liver. So if someone has like liver disease, obviously you want to be careful about that. If they're a chronic alcoholic, obviously you want to be a little cognizant of that. I want to make sure their kidneys are doing okay. And if it's below 50 with the GFR, so if you do like labs and if you do what's called a complete metabolic panel, you can see what's called a GFR. So that's going to be glomerular filtration rate. And it should be like everyone walks around, should be like roughly around 100 to 125. But the second it stops dropping below like 90 and 60 and 50, that's where it's a sign of your kidneys are obviously not functioning at full capacity. So if it is below 50, you're going to have to reduce the dose. Okay, the good thing about this is you can give it to kiddos. So if you're in peds and you're like, shit, this kid has a fever and they're like 7 months old, what can I give them? Voila, you can give them Tylenol. So that was something I didn't know. And I was always hesitate, like, shit, you can give like little infants and kids drugs. That's kind of fucked up. But yeah, you can actually give them Tylenol. It's fairly safe. Obviously, don't smack the shit out of them with it. But yeah, you can use the correct dosage for peds, and it's useful in that sense. Okay, so a quick way to remember a little bit about Tylenol is just think the T and the L at the beginning and the end. So T is for Ty, and it rhymes with 325. Well, it almost rhymes, but it's the best I can come up with. And then think of like a game like either soccer. If you're not from the US, think like football. That's about 4 hours long. So you give it every 4 hours. And just think of toddlers, you can give to kids. And then liver, you want to beware. All right, next, NSAIDs. So I put Toradol in here because I saw something interesting on shift like a couple days ago. So that's kind of why I like want to pinpoint Toradol. So these are going to be NSAIDs, and it stands for non-steroidal anti-inflammatory drugs. So this one is for pain and is for fever and is anti-inflammatory. So if your knee is swollen or you have back pain or your joint hurts, you're going to use this guy. Okay, the way that it functions is it inhibits these two entities, which are called COX-1 and COX-2, and then these essentially lead to making what's called a prostaglandin, which is short name for PGE. And I'll explain on the next slide why that's important. So an example of an NSAID, like if you say Motrin, ibuprofen, that's essentially what it is. It's 200 mg every 6 hours. Okay, so I don't have a mnemonic for the very first part of the slide, but I do have a mnemonic of when not to give these to people. So you can see here that there's going to be side effects of renal issues, possible GI bleeds, pregnancy, and then platelet aggregation. It messes with that. So the way to remember this is use NSAID. These are who you're not going to give it to. And I'll further explain this on the next slide as to why you don't give it to these, groups or entities of people. So N is going to be for nephro. Nephro means renal as in your kidney. So it causes kidney issues, hence why you got to be careful of that. S is for stomach, as in that can give you like GI bleeds, GI ulcers, and I'll explain on the next slide. Advanced age, like seniors, you don't really want to like pellet them with NSAIDs because of the first two issues. When you get older, your kidneys start to suck and you start to get more of like peptic ulcer disease from like grandpa like drinking and smoking a fifth every day. So that's essentially why I don't want to give to older people. It inhibits platelets, so you got to worry about bleeding. And then the D is going to be for PDA. So it's called patent ductus arteriosus. So when you're a baby, you have what's called a PDA. And if you give someone an NSAID when a female is pregnant, you can actually close that by accident. And I'll further explain what that means on the next slide. So just remember NSAID. So nephro for kidneys, S is for stomach, A is for advanced age, I is for inhibit platelets, as in like thinning the blood and it can't coagulate or stop bleeds. And then PDA. So just think of the D. So it's for the PDA from when you're pregnant. Oh, and Toradol is great for back pain and kidney stones. It works wonders. Oh, and one last thing. I keep forgetting I put this damn thing in here. So up in the left-hand corner here, you cannot give NSAIDs like ibuprofen to under 6 months old. So meaning that if a kid is like 7 months old, you're always gonna hear this feel of like, hey, like you can do Tylenol and alternate with Motrin on and off for like fever and like having like a viral upper respiratory infection. So as long as you're over 6 months, you can give the Motrin or AKA ibuprofen and the Tylenol. So I just wanted you to be aware of that. And then at the bottom here's a little bit of extra information that's going to be explained on the next slide. Okay, so real quick. So PGE, which I said it before, is a prostaglandin. So these are just made in your body, and you're going to do these three things here. Starting on the left, in the kidneys, you have essentially a hose that goes, or a vessel like a hose, going into the kidney and then coming out. So going in is afferent, leaving would be efferent, starting with an E. Think of like exit. So what PGE does is it dilates, meaning more blood flow goes to the kidney, making the kidney more happy. It can filter shit, get rid of it, and then your body's happy. And then in the middle here, your stomach has mucus secretion. It has certain cells that spit out mucus because your stomach has a lot of acid. It needs to break up the contents that you're ingesting. And it also has to protect yourself and your stomach from this like very acidic environment. So that's what the mucus essentially is. It's like, protection layer of your stomach so it doesn't eat itself. So the PGEs do that. And then also when you're like a neonatal or you're, a fetus, like you're in the process of being, made and essentially you're going to be going through pregnancy, is that the infant has what's called a PDA. So it's called a patent ductus arteriosus. So you'll notice that a infant is literally not breathing air because they're literally surrounded by amniotic fluid. So that being said, they're not going to be using their lungs. So when blood circulates into the heart, it cannot circulate towards the lungs because they're clearly not being in use right now. So what it needs to is bypass that, and that's through what's called the PDA, which is the patent ductus arteriosus. So it goes from the pulmonary artery, bypasses the lungs, and then dumps in the aorta, and then goes to the rest of the body, and then oxygenates, rest of the perfusion of the organs. So that's how it works. So it keeps that open during pregnancy. And then when the baby's born, pressure changes and the PDA closes, then oxygen that the baby's actually breathing will actually go into the lungs, open that up, and then the circulation will go through, and then the PDA will actually close in about 72 hours, then officially in like about 3 weeks. So, sorry, that was a very long rant on PGE functions. Okay, so let's see what happens when you add an NSAID. It's going to essentially do the complete opposite. So what it's going to do is it's going to constrict the efferent arteriole in the renal function. So essentially like clamping the hose, and it's going to make the kidney very unhappy and cause acute kidney injury. So that's what can happen if you are giving somebody NSAIDs. And then NSAIDs destroy the PGE, therefore it's going to decrease mucus, therefore you're going to be more susceptible to having peptic ulcers and GI bleeds, which is a big no-no. No one wants that. And then what it can do also is it can actually shut off the PDA. So essentially, when you give NSAIDs, these are the reasons why you don't want to give them to these people. That if I back up here, you don't want to give them to NSAIDs. You don't want to give them to people with renal issues. You don't want to give them with people that have peptic ulcer disease or they have GI bleeds, old people, and then people are taking blood thinners and anticoagulants, or they can't bleed or have a bleeding disorder. And then you don't want to give them during pregnancy. So that is the whole reason of this. Okay, I think I beat this enough to death. Okay, let's move on to the next drug. Okay, codeine. So you probably heard of codeine. You can use it as like an antitussive, which means like anti-cough medicine, but it is an opiate. So it is a mu agonist. It's used for pain and sedation. It's by mouth only, which means PO. And we don't really use this anymore. I just threw it in here just for completeness sake. So you can use it seldomly when you send home through breakthrough pain. So if someone like, you know, broke their wrist or they just had a incision and drainage of something, they're going to be in a shit ton of pain. So you can give them like 5 pills of these just to kind of keep them simmering down until they kind of get over the hump of like the extreme pain post whatever procedure they had. This is a typical dose and the amount of hours. I'm not going to really go through that shit because we don't really use this very much. Okay, so here are things you're actually probably going to see when you actually prescribe it. So you can use hydrocodone, which is Vicodin. And the reason I highlighted or bolded hydro and then V, just think volume. Volume is hydro, think hydrate. That's how you can kind of remember hydrocodone is Vicodin. You're going to do about 5 to 10 mgs and then plus Tylenol, which is Ty 325. See, it does rhyme. You're going to do it for 4 to 6 hours. And then you have oxycodone, which is percocet. And you can see that the O's and O's go together, so that's how you remember these. And again, the dosing is roughly the same with Tylenol. So codeine, it needs to be chopped up and metabolized by this enzyme CYP2D6, and then it gets converted to morphine. Now, the problem is there can be hyperconverters, meaning like kids, or hypoconverters. So this means either you can get too much of like the effect and it works too well, or nothing happens. So you can give someone like Vicodin and they're like, dude, I don't feel anything. This isn't helping my pain whatsoever. Well, that's why. Side effects are nausea, vomit, dysphoria, and this is more than any other opiate. So you have to be really careful with this stuff. It's highly addictive. It is an opiate. Um, it's not going to cure all pain. It can help with breakthrough pain, but you have to be very conservative when you do write the prescription or you're going to lean towards using this drug. And it does have the side effect of severe respiratory, not severe, but it does have the susceptibility of having respiratory depression, especially when you mix it with other like medications that are depressants or you're drinking something like alcohol. So if you hear like musicians that are like singing about like, oh, I took a Percocet and I had alcohol, like, and they end up dying from that, well, that's because they mix the alcohol and the Percocet. So you shouldn't do that because that's going to lead to two depressants making you respiratory depressed, therefore stop breathing, therefore you die. So just fair warning, don't use Percocets and go have a fun weekend with alcohol. Please don't do that. Okay, so Tramadol. This is another opiate, but it's one of those weird ones, and I threw it in here. Again, we don't use this one very much, but it's in here for completeness sake. I'm literally just trying to get to the last four, because those are the ones I'm really excited to talk about. Okay, so it's a weak mu agonist. This one's a little different because it blocks SE, which is called serotonin, and then NE is norepinephrine. So these are both neurotransmitters. So if it blocks reuptake, that means there's more of it sitting around in the synapses. So essentially it increases where it needs to actually function. So dose, I really don't give a shit telling you the dose. You can read that. You have to be aware of serotonin syndrome. So if they're taking like, I'll show you later in the slide, but if you're taking like antidepressants or something else that's increasing serotonin, you can have what's called serotonin syndrome. And if you don't know what that is, that means like you see a patient that has like hypertension, really high sympathetics, meaning like increased blood pressure, they're diaphoretic, meaning they're sweaty, and then they have this one little symptom, what's called clonus. So they have like repetitive jerk movements. In cartoons where people memorize this stuff, it's usually the foot, but essentially it's just like rapid repetitive movement, and that can be indicative of serotonin syndrome. Okay, this one depends on a CYP450 enzyme. And again, this one's not often used. You got to be aware in IV drug users, antidepressants, because of the serotonin and the serotonin syndrome that I mentioned. And it does have a warning that tramadol can lead to seizures. So you have to be really careful with that. It's not for kids or people that are pregnant. The reason I mention this is it is cheap. So people can use it, but this isn't really going to be like one of my first go-tos I would reach for when someone's in pain. Again, it's going to have side effects of dizzy, nausea, constipation, headache. And fun fact, it can cause a false positive on a urine analysis for phenylcyclidine, meaning PCP. So I just threw that in there because I thought that was kind of funny. a little bit of tidbit right there. Okay, so now to the good stuff. So if someone comes in and they're like in agonizing fucking pain, I mean, like they are screaming, they're having, let's say they have like acute pancreatitis, that shit hurts. Like they are in a lot of fucking pain. Like the first four we talked about aren't going to touch this. So like you need to pull out the big guns. So the next four that I'm going to talk about are the big guns. So first on deck is morphine. Okay. So MOA means mechanism of action. It is a strong mu agonist. This is a strong opiate. It's going to be used for analgesia, which means pain, sedation, and then euphoria. Dose is going to be 0.1 mg per kg. And then for like 70, yeah, if you do the math, it would be 7 mgs. But generally, the first dose is going to be 4 mgs. Its onset is quick. I mean, it starts in like minutes, which is awesome. So if someone's, raving in pain, they're ripping shit off the walls because they're just agonizing pain. Give them this, it'll start working for pretty damn quick. And what's awesome about morphine is it's long. So like you shoot them once, it should last a good 4 or 5 hours. So that's 5 to 6 hours, which is awesome because if you use other drugs in the future that I'm going to talk about in the next 3 coming up, some of these don't last as long. So if you're busy and you just want to like quiet this person and get them to like calm the fuck down, you can shoot them once with this, and that should keep them nice and smooth for a good 5, 6 hours. So that's like a nice little tidbit that works with morphine. So side effects, as you're going to guess, because there's an opiate, it's going to cause like nausea, vomiting, hypotension, histamine release, sphincter of Oddi. I think I said that correctly. Essentially, it's a musculature where like the biliary tree from the liver comes down and meets with the pancreas, and then it spits out essentially like bile and then like pancreatic enzymes into the duodenum, which is like the beginning part of your small intestine. So you don't want to give it to that. So if someone does have pancreatitis or has like cholecystitis or gallbladder disease or anything that has to do with the bile or the pancreas in that area, you may want to think twice about morphine because it can cause that to constrict and then make the symptoms worse. So just be aware of that. And then main thing is respiratory depression. So if you give too much morphine, they can stop breathing and you can kill them. So you got to be careful about that. Again, don't use it for renal impaired. So if it's below 60, think twice before using morphine. So get a metabolic panel first. It'll tell you the GFR. If it says above 60, give them morphine. Okay, so this is the first really good mnemonic. So how the hell are you going to remember all of that, what I just said, considering this is a very important drug? Well, we're going to use the word morphine. So M is going to be for mu agonist. O is going to be for 4. Just think more is 4. Those also rhyme. You're going to use 4 mgs. It's a common dose for an adult. Do not quote me for a kid or like a 90-year-old. I'm talking like an average 70 kilogram, like 40-year-old person. So like that's what I'm talking about. That's like the most standard, most commonly used dose. It can change. You can do little, you can do a little bit more if they're, like 300 kilos, which would be a ton, but it can vary. But the most common dose is going to be 4. So next, it's a rapid onset, which is awesome. It does cause respiratory depression, so you have to be careful about that. It does cause hypotension. So if their blood pressure is already soft, let's say it's like 90 over 65, you don't want to slug them with morphine because you're going to further drop it out. And if you bottom them out, they could literally just become hypotensive and they can start coding or stop breathing. So like you do not want to do that. So be very aware of not to slug somebody with morphine if their blood pressure is already soft. Again, sphincter of, I think it's Oddi, not Audi like the car, but Audi. You know the hell I'm trying to say. Don't give to people with pancreatitis or having like kind of like biliary type of issues at the time. So be careful and be cognizant when you use that. And then no renal, so the 2 N's. So it's below 60 GFR. Don't slug them with morphine. But yeah, so this is a nice mnemonic. Just think like the whole point of morphine is if someone's in a shit ton of pain, their kidneys are fine. It's it's not their gallbladder, it's not their liver. And their blood pressure is like 160 over 110 because they're in so much pain that their blood pressure and their heart rate are sky high, and you really want to chill them out for a good 5, 6 hours, give them this. Okay, so that's morphine. Oh, and E. Sorry, I forgot there's an E in the end. It lasts forever, so 5, 6 hours. I was wondering where the hell the timing was. Okay, perfect. Okay, next, fentanyl. So very similar to morphine, acts essentially the same. It is 100 times more potent than morphine, so it's a synthetic opiate, meaning that like it's not natural. Like morphine is natural. Fentanyl is something that was made in a lab and it doesn't like naturally exist. So again, strong mu agonist. It's used for the same reasons. So pain, sedation, euphoria. Dose. Now notice this is mcg, which is micrograms. So 1 milligram has 1,000 micrograms. We're using 1,000th of a milligram. So this is a very, very tiny dose. So like be very cognizant of that. So I'll use my cursor. See how it says MCG? Be very careful that it doesn't just say MG, okay? I don't know why that's there. It should just say this, so fuck that. Okay, again, onset is rapid. The duration is not as long as morphine, so it's actually pretty quick. And this can either be a benefit and kind of work against you. So if you want to shut someone up because they're in so much pain, I hate to say it that way, but when people are screaming, it scares other patients. You kind of want to get this person under control. And if you want to slug them with something, you can slug them with this. The only issue is it's going to wear off in about an hour and you may have to slug them again. So do be aware of that. Morphine's kind of like one and done versus fentanyl. You may have to shoot them a few times. The good thing is it doesn't mess with your hemodynamics. Therefore, if they have a soft pressure where you don't use morphine, you can actually use fentanyl. So that's actually a huge plus. It doesn't last, it doesn't have a quick duration of time. So it only lasts about 1 to 2 hours, and it doesn't bottom out your blood pressure, which is awesome. And it won't mess with your respiratory drive as much. Shorter duration, like I already said. The weird thing that it can do is called a chest wall rigidity. It's like when you push it too much through the IV, when you're administering it, it can cause this like chest wall rigidity. So just be aware that it has this weird side effect. You may be asked that on either exams or when you're doing your clinical rotation. So just be aware of that. And then down here, just showing that 1 mg equals 1,000 micrograms. Okay, so the way to remember fentanyl and everything I just said, we're going to say F's given. So first off, receptor is going to be few, rhymes with mu. So it's a mu agonist. It is a fraction, meaning that it's like 1,000th of a milligram. So it's 1 microgram per kg. So keep that in mind. It's a very, very small amount. You do not want to give 1 milligram per kg. If you give 50 mgs of this stuff to somebody, there's a good potential that you could fucking kill them. So please don't do that and just pay attention to your actual units when you're trying to think of the actual initial dose. So the starting dose is going to be 50. So that's the next F. You're going to start with 50 micrograms, not milligrams, but micrograms, okay? A very small amount. And then use is going to be fucking anal sex. So it's going to be pain, sedation, and then euphoria. Timing, it's fast onset and offset. So it only lasts 1 to 2 hours. So that's awesome. It's fully functional, meaning that it's not going to mess with your hemodynamics. It's not going to bottom out the blood pressure, which is awesome. And then the weird side effect is you're fenced in, so chest wall rigidity. So that's one of the weird things about it. So yeah, as the F's given, so it's few mu, it's a fraction, it's a smaller dose. You're gonna get 50 up front, and then fucking anal sex is what it's used for. So pain, sedate, and euphoria. It's fast on and off. It's fully functional. You don't have to worry about blood pressure as long as you dose correctly. And then the weirdest side effect you just gotta worry about is fenced in. So that's fentanyl. And then examples, just some math if you feel like getting into that. I'm not going to, you guys can use your eyes, you guys can read and do math. I hope you can do math at this point. All right, so moving on. So Dilaudid, so hydromorphine. This is a big boy. I'm just going to essentially talk about it. This is kind of like last resort. Of the three, I would go like, essentially order of potency. So I'd go like morphine, fentanyl, and then Dilaudid. So this is like the last big boy hitter that you're like, holy shit, like someone's in serious pain, like you're about to do an incision and drainage. They are doing like a 20 out of 10 pain scale. You may want to select them with this, but again, got to be very, very careful with this stuff. It's very strong. So obviously it's a mu agonist. It's an opiate. It's used for the same shit. It's 5 times stronger. So you can use 5 times less than morphine. So morphine was 0.1. So you're going to use 5 times less than that. Okay. It's rapid onset. It's kind of in between. It's a little bit more than fentanyl, a little bit less than morphine. And you're going to slug big boys with this one. So if someone's really big and they just can't hold still for whatever you're trying to do, whether it be, shoulder reduction or, incision and drainage or some, shoulder dislocation, whatever it may be, if they're just screaming, you may want to consider this. May try one of the first ones first, and then after an hour, if they just can't calm down, and then you try fentanyl, and then this is pretty much your last ditch effort. Like I said, use as last resort. And it's notorious for respiratory depression. Like you can kill somebody with this stuff. So be very, very careful. So again, the D's for Dilaudid is dangerous and last ditched effort. So just keep that in mind. Okay, so I threw this in here. Ketamine, this is more like a sedative, like what you can use to intubate somebody. That means like putting a tube down someone's trachea to help them breathe, but it can also be used for pain. And it's actually really wonderful for procedures. So I added ketamine into this, category of pain control. So it's used for analgesia and amnesia, and yes, you can give it to kids. So I just think ketamine is like nice and simple. So it's 1 mg per kg, and you can use it with propofol, and I'll explain why in a second. So what it is, it's an MDMA antagonist. So it's dissociative. It's not something that's going to conk you out. It's just literally disconnecting from your being conscious awareness to what's like literally going on upstairs. So like when someone is given ketamine, they still look like they're awake and functioning, but they have no idea that they're actually like, interacting with the world. They're kind of like having a dream like they're asleep, but they are like essentially up and moving and talking. They're not going to have any recollection what it is, any recollection of it. They're just like in a dream and they have no idea that whatever you're doing in front of them is occurring. It's called the K-hole. So the one thing that can happen is they can have bad hallucinations when they're coming out of it. So it is a PCP derivative. If you look at my other videos on drug overdoses, it does talk about PCP. And one of the side effects of it is called nystagmus, meaning when the eyes kind of flicker back and forth. And it is a little scary. So if you are going to give this to kids, tell their parents that up front, because if they're like, why the hell are my kids' eyes moving back and forth? It's a normal side effect of the drug. So vitals, this one's interesting. Instead of worrying about your blood pressure and your vitals going down, ketamine actually makes them go up. So it actually increases heart rate, your blood pressure, and doesn't cause any hypotension, which is why you can give it with propofol. So this guy right here, this is also a sedative, what you can use for induction of anesthesia. And that's like the, kind of white milky stuff that Michael Jackson apparently overdosed on. So that's what you can use. But the problem is this causes severe vasodilation and hypotension. So if you have a drug that goes up, you can add a drug that goes down, and it kind of meets in the middle of having like a nice smooth middle where the blood pressure isn't too high and the blood pressure isn't too low. So you can actually give these together. When you're doing a procedure, you're trying to sedate somebody and give them pain relief. Duration is really quick. It's 30 minutes. The thing is, when you're using kids, you got to worry about this weird side effect, is that if you push it too hard, you can give them what's called a laryngospasm. So meaning the larynx, like the part where the vocal cords are, what can happen is that can actually clamp down. And unfortunately, the kid can stop breathing. So what's going to happen is when air tries to go in and then CO2 comes out, it gets trapped. So your CO2 that you're detecting on the tube is actually going to start going up and skyrocketing internally. So like that's I think I might have that wrong. The whole point is you're going to have CO2 retention, and you're going to be like, oh shit, like we need to actually like force air through it and essentially push it through the vocal cords to get into the trachea. And the solution to that is a bag ventilation. So essentially, if you bag them until the drug wears off, it'll correct itself. All right, so how do we remember this? So it's going to be ketamine in kids. So ketamine with the A's, you're going to have analgesia and then amnesia, meaning they're not going to remember anything, and it's also good for pain relief or control of pain. Hence why this video is called that. Ketamine is for kids, and just look in the middle of kids is an I, and it's 1 mg per kg. And just think kids are easy, so 1 mg per kg, not hard to remember. Can't remember, so it's dissociative. Kids are hyper, so think of increased heart rate, blood pressure, no hypotension. And then kids are short, so it only lasts a short period of time of 30 minutes. Kinked, which can be the laryngospasm, which is the side effect that you're having. Again, I already talked about that. All right, so that's ketamine. So it's ketamine plus kids. So the A's, K for kids, and the I's for 1 mg per kg. You can't remember. Kids are hyper, kids are short, so it doesn't last very long. And then kinked is laryngospasm. So that's ketamine. So bottom line, I'm just going to give a few situations like when you should use which drug versus the other. So if you have a 35-year-old patient who comes in with acute pancreatitis, their blood pressure is through the roof and their GFR is 100, which means it's over 60 is totally fine. That means you can technically slug them with morphine. Again, I know you shouldn't use this with a sphincter of Oddi, but if someone's in agonizing pain, it should be okay to be used with this. So it lasts long, it lowers the blood pressure, and kidneys are functioning just fine. So again, if you have a 6-year-old male with soft blood pressure, it's 90/65. That's pretty shitty. And they're having a kidney stone. Well, you're going to give them fentanyl because it's not going to be affecting their blood pressure. Then if you have a 35-year-old male, he's healthy, GFR 100, and he has back pain, and less likely to have GI bleeds, and clearly it's a male, so he's not pregnant. So you can give him Toradol, which is the NSAID. So they're not pregnant, their kidneys are fine, they're not bleeding, and they're young. And again, like I said before, Toradol is great for back pain and kidney stones. And then last one. So if you have a 3-year-old kid, they need either a facial suture repair or a bone reduction or like a shoulder dislocation. you want to give them ketamine because it's for pain relief. They're not going to remember anything, and they're going to hold still, which is great. So that's the bottom line. Okay, so those are all the drugs. Okay, so that actually went pretty quick. So this is gonna be a recap. This is essentially just a slide of like the actual main mnemonics. If I didn't have a mnemonic for it, I didn't put it in this table, and I have 2 slides for these. So here's gonna be Tylenol, NSAIDs, and morphine. So I'll just give you a second if you want to screenshot this for your own pleasure for studying purposes. Okay, I'm gonna go to the next one. So this one's for fentanyl, Dilaudid, and ketamine. And you'll have mnemonics on the right. Give you guys a second. All right, moving on. All right, so yeah, that's the video. This is pain control. So I really wanted to do this video because when I was asked this question, I was like, holy shit, I don't know whether I should get fentanyl or morphine. Like, I didn't really know anything about the drugs. And then trying to look them up, like either in certain textbooks or certain like publications, like articles, I really couldn't find anything that told me like, hey, use one versus the other. There was like 1 or 2 videos, but I had to really, really dig for these. And again, they didn't really get at the whole point of like when to use which one. Like you have to ask these main questions of like, are they young or are they old? Are their blood pressure, is it shitty or is it not shitty? You know, are they in a shit ton of pain or some pain? Are they having back pain or are they having kidney stone? Like, are they pregnant? Like, you gotta ask these types of questions of when you can pull the trigger, when to use something, and when not to use something. So, from that standpoint, I thought this is a great introduction to these medications. I know I'm not a pharmacologist. I know there's probably a better video somewhere buried under the millions of videos that are out there. But I thought this one was a very good introduction to like how to make a clinical decision of when do you slug somebody with something when they need pain treatment, like right now. So that was the whole point of this video, and yeah. So hope you guys enjoyed it. If you really did, smash that like button. And if you want me to make more videos and to entice me to make more, hit the subscribe button. So it kind of gives me an indicator to make more videos and indicating that I'm not doing a shitty job at making these things. So yeah, that being said, I hope you enjoyed the video and I'll let you guys get back to studying. And I love you guys and I hope everything's going well and good luck to start this year. All right, see you at the next video. Okay, peace.